Good afternoon, everyone. Thank you for coming back after lunch, and thank you, the organizers, for the invitation, and Martin, thank you for your introduction. So, you got just one question, and I will be curious about your answer about the clinical use of NGS in the near future. And I would like to talk to you about the pros and cons and the problems that we face right now and maybe in the next years. So, as you all are aware, when you treat patients, when you diagnose patients with MDS, today the scenario of different methods is a broad spectrum of different approaches with morphology, with histology, cytogenetics. This is all needed for IPSSR, for example, maybe combined with FISH, immunophenotyping or immune histochemistry, and the question is now molecular investigations as well, and how and why and when. And Luca Malcovati published this very good ELN recommendations about the different methods that can be used in MDS patients, and they described here patients with these diagnostic approaches as being mandatory, recommended, and suggested. And within these suggested, they are SNP arrays for the detection of chromosomal defects at a high resolution in combination or instead of metaphase cytogenetics, I would add, and especially mutation analysis to detect somatic mutations that can allow us to conclusively diagnose the patients or maybe also pick up some important, maybe independent prognostic markers. So having said that, this new classification published 3 weeks ago, and Mario Cazzola also referred to it in his talk about MPN categories, also gave us some new clear-cut ideas about the MDS cases. We all have to change our habits to call it refractory anemia because now it's all MDS with something. And with respect to the question, molecular markers, next-generation sequencing, this is a very, very small step in this new classification because at least we have this ring sideroblast here and this over 5%. What does this mean? That means that if you go for ring sideroblast between 5 and 14% and you investigate SF3B1, you can also call it MDS with ring sideroblast. So we need to focus in this specific patients with ring sideroblast between 5 and 14% on a molecular marker to call this patient MDS with ring sideroblast. This is the first step of molecular genetics into this classification. And we know that there was another specific category based on morphology and cytogenetics already given as a unique entity in 2001 and 2008. That means that patients with a 5q- syndrome that is more or less specific with respect to these specific megakaryocytes, and for sure a very specific cytogenetic feature. Those patients were also known to be of a very good prognosis, at least that was in the IPSSR when they show a 5q- SOL, or if it is combined with one other a mutation or deletion in the karyogram. And what does it mean for the new classification? In the new classification, there's also the allowance to call this MDS del5q if there is one additional cytogenetic aberrations, but not including chromosome 7. And it is suggested, it is not mandatory, to investigate p53 mutations by molecular studies or by immunostaining to risk stratify these patients better than before. So why is this? Our chair published in 2011 a paper in JCO that demonstrated clearly that those patients showing p53 mutations have a worse outcome if they have a 5q- syndrome. And this is not a rare event, because if you look into our data set in 115 patients with 5q- syndrome, you see that in 17%, and this is quite the same range that you also published, Martin, they show a p53 mutation by molecular studies, and a new gene has further been published last year. This is this gene where we don't know so far what does it really mean, but if it means something, it is also showing a worse prognosis, and it is mutually exclusive of all these patients that show p53 mutation. So we now see that in the background of p53 and this gene and 5q- syndromes, we should be interested to get more information on the molecular side of the respective patients. So can we know more by molecular markers and how far we are away from the clinic? So first of all, how could we make these diagnoses of MDS more objective? I would like to refer your attention to SNP arrays, and we did a great big study on this, a large study with 520 patients with MDS, and they all had a normal karyotype within this paper in Leukemia 2014. And we addressed in all these patients the DNA with array CGH, and this is the diagnosis from the respect of the morphology. And the question is, what did we pick up in all these patients that have been shown to be in a normal karyotype? So we picked up some very rare cases where patients showed bigger deletions or gains or losses that should normally be picked up also by chromosomes, but the respective metaphase doesn't grow. But we picked up a lot of gains and especially losses in those genes. So that seems to be there something more than just the karyotype being normal. And the question is, if we use this method that was only suggested in the ELN guidelines in 2013, does this mean anything for the patient's outcome? And the answer is yes, it means something, because those patients with a normal karyotype that did not show any deletions by array CGH have this outcome, and those with the detection of some deletions by array CGH had a worse outcome, what is statistically significant. So we can get more information using such a molecular method to more subclassify, especially those patients that showed a normal karyotype by cytogenetic banding analysis. However, the question of next-generation sequencing is of much more importance. And this is our, I may say, learning curve in the last 5 years with respect to what instruments, what assays came into the field and left the field already. So the turnaround time of the instrument is very quick. It's below 5 years, because the whole system of next-generation sequencing with respect to instrument and assay is moving so quickly forward that it is problematic to be in the right time to get the right instruments. So we changed a lot of approaches over the last years, implemented and gave away some of the assays, and I would like to share with you what we are doing right now. First of all, you need some information on the DNA and the RNA, and you want to go for specific genes, and we are normally using amplicon sequencing and not whole exome sequencing or whole genome sequencing. And by doing this, you are interested to get a lot of information on patients and genes in parallel, so you can use an assay like that with 48 patients' DNA and 48 different amplicons for respective genes. You can put 10 amplicons per vial. So you run within 1 hour 2,304 PCR reactions in such a little tool. There are other instruments like this one here, where we can use 2 million little droplets with the respective amplicons you're interested in the patient DNA, and by electroevaporation, you get the DNA into the respective little droplets and then go for PCR and then go for sequencing. So finally, you are on the way to go for the sequencing machines by preparing the DNA on that way. And we did a lot of different assays in the last 5 years, and this is the history of what we tried to do and what we are doing right now. So what you see here are different combinations of machines and assays to go for next-generation sequencing in myeloid malignancies. The turnaround time decreases to around 4 working days right now. It will be quicker if the machines are not running for 36 hours in the next future. The input of DNA per patient decreases a lot. It's only 80 nanogram of DNA that you need to put into the system right now. And finally, you can go for 75 patients per run, investigating 23 genes in parallel. So that tells you that if you want to implement it like that, you at least need some patients to do this, because for your own facility and some patients a day or a week, you need to take some time to get all these patients for one run. What are the genes that we investigate in one approach? These are the genes we are investigating right now. And if you look here at all these genes, you see very quickly that these genes are of interest for myeloid malignancies, AML, and MDS. And especially you get information on those genes that are prognostically relevant and are going along with the bad prognosis in MDS cases. We also test a new assay that looks for up to 200 fusion genes in one approach. We are quite sure that that can be done on an RNA basis also very quick. We did just a beta site testing for Illumina, and we picked up all the different mutations that are sometimes very rare in this one approach assay, addressing more than 150 fusion genes in one test. So, however, the readout is a problem, because this is how it looks like, and without a lot of bioinformatic help and a lot of software tools that automatically make the data available for your investigations, for your reports, and especially for going to contact the international databases to look if this is really a mutation, if this is only a variant of unknown significance, or this is a SNP. You need a lot of software tools, and they are normally not implemented as you need them in the machines you buy. So what does it mean? And this is what we do, automatically address all the information we get from our next generation sequencing to those international databases that are in the web, and they have different information available to help you to really know what it means that you picked up. And by just some seconds, we get information on a mutation we picked up with a patient from Cosmic, from mutation prediction software, from IRC, from ClinVar, from DBSNP. And all this in combination is needed to get the information to the bioinformatician, as well as especially to the molecular biologist, and at latest to your desk. What does it mean, what you picked up, and how can I translate this knowledge into patient's care and patient's prognosis? Why is this so problematic? Because if you look in one of the best databases that is just promoted also by the NIH and the NCI and the American government, a lot of submitters, a lot of genes that are submitted were only submitted by one submitter, and very few have two or more submitters. But even if it is like that you gain information on a specific mutation by 2 or 3 submitters from all over the world, there is a problem that in 21% of those, the interpretation is different. Some submitters say, this what I found is a damaging mutation, and the others say, well, it's a benign thing, and I don't think it means anything. So we are in the very early phase to know about all what we pick up, what does it mean to the patients, and this is the unsolved problem right now. So with respect to the instrument, they are, as I said at the beginning, are increasing very quickly, and you can go for a lot of information with very small instruments. This is just an idea from one of the companies. You see the runtime here, it goes down up to 4 hours. You can go for exomes or genomes, but especially for the need I think we are needing right now with respect to the MDS cases, we go for amplicon sequencing. What does it mean? I think in the next future we will go for specific DNA and RNA preparation for MDS patients, but also for other malignant hematological diseases. Implement in the DNA processing a specific sample, specific index for the respective patient, in parallel for RNA the same. And then finally, you can go on the same instrument in the same run, and the software tools helps you to address the DNA-based questions and the RNA-based questions, and finally leads to your readout and can be implemented into the report. This is already done by some colleagues, and this is the paper from the colleagues from the Memorial Sloan Kettering from New York. What they did is, together with Foundation Medicine, they investigated more than 3,800 patients with hematological diseases on DNA and RNA. And they also implemented MDS cases, as shown here, but also AML, non-Hodgkin's lymphomas, multiple myelomas, and a lot of other hematological diseases. And they did not investigate 1 gene, 5 genes, 23 genes, but what they did is they investigated this list of genes, but this is not the complete list. They also investigated this genes, and they investigated this genes. So finally, they investigated more than 400 genes, and they were able to get into the real world and characteristics of these patients based on their genetic and molecular genetic level by next generation sequencing. So if you would ask me the question I have to address in that talk, is NGS ready for clinical use? Yes, it is. You need to follow up guidelines. You need to address especially the problem, not how to get this instrument in your lab and how to start with the assay, but to investigate the tight data set. Are you quite sure what you are measuring? What is the coverage? What is the sensitivity of the system? And you start, however, still with morphology, with iron staining. You go for cytogenetics because you want the IPSSR. You may address, I didn't talk about that, immunoflow. But finally, a lot of assays that we run right now, step-by-step, wise procedure, 1 gene and the next gene and the other gene will be very soon solved by going for gene panels, 20 genes, maybe 400 genes, I don't know. And therefore, NGS will be the method of choice to get into the molecular world of MDS in the very next future and will be also implemented in the new IPSSR that will then finally maybe called IPSSM for molecular, including information from morphology for sure and from cytogenetic using bending chromosome analysis. Thank you very much for your attention.